Chapter 56, Breast Problems. The first issue we'll discuss is mastalgia, or breast pain. It's the most common breast-related complaint and can come in two forms. First being cyclic mastalgia, which coincides with menstrual cycle, or non-cyclic mastalgia, which can be constant or intermittent. It could be due to trauma, necrosis, and reassure the patient that any signs of breast pain are not necessarily cancer. The next would be lactational mastitis. This is an inflammatory breast condition that occurs most often in lactating women. Localized area that's red, painful, and tender to palpation, with a fever often being present. Pathogens gain access through the cracked nipple, and this can be cured with antibiotics in the early stages. Other issues while breastfeeding include lactational breast abscesses, from persistent lactational mastitis, and this would involve a palpable mass with red edematous skin involved over the breast and possibly even a fever. It could also include things like a drainage of the abscess being necessary. You would use an ultrasound guided needle or surgical incision to go in there and drain the abscess. Other issues could arise from fibrocystic changes within the breast. And this is another benign condition with changes to the breast tissue itself. In this case, they develop excess fibrous tissue, hyperplasia of the epithelial lining of the mammary ducts, and proliferation of mammary ducts. Most often occur between females between ages of 30 to 50, and women with premenstrual abnormalities, nulliparity, history of spontaneous abortion, and non-users of oral contraceptives. These fibrocystic changes are possibly due to an exaggerated responsiveness to their hormones, namely estrogen and progesterone, and is not linked to increased breast cancer risk. Bone or more palpable, round, well-delineated, freely movable lumps, discomfort ranging from tenderness to pain, and the lump usually increases in size and tenderness before menstruation, and could also include some nipple discharge, often green or dark brown. And in figure 56.2ab from our textbook, on the left we've got a normal, healthy breast with the mammary glands right there in the center. And then on the right, we have a diagram of that cyst formation within that tissue. There may be a wide variety of interventions used to identify these growths. The first would be mammography or a mammogram, which may be used to help distinguish fibrocystic changes from breast cancer. In women with dense breasts, an ultrasound may also be used. You could also use interventions like an aspiration or biopsy, even an excisional biopsy, meaning no fluid on aspiration, the fluid is hemorrhagic, or the residual mass remains after fluid aspiration. A common cause of discrete benign breast lumps in young women is a fibroadenoma. This is a painless, round, solid, firm, or rubbery growth that is slow and ceases at approximately 2 to 3 centimeters. Fortunately, these fibroadenomas are easily detected by physical assessment, and then treatment would be observation with regular monitoring after ruling out cancer. Surgical removal could be indicated if it increases in size or becomes symptomatic. All new lesions should be evaluated by everything from ultrasound or a possible biopsy to make sure we're definitively ruling out cancer. Moving on to slide 11, nipple discharge or galactorrhea. These are milky secretion due to inappropriate lactation. May result from certain medications, endocrine or neurological problems, or may have an unknown cause. Nipple discharge can take many forms, from clear, serous, and bloody, to brown to green secretions. Cytology would be used to determine the cause and the recommended treatment for this discharge, and could have underlying causes related to fibrocystic changes, intraductal papillomas, ductal ectasia, usually not caused by cancer. However, spontaneous unilateral discharge definitely needs further evaluation. Intraductal papilloma. This is a benign, softer, hard, wart-like growth within the breast, usually occurring in the mammary ducts, and usually unilateral, meaning it's only happening in one. Could also coincide with bloody discharge from the nipple, and is difficult to palpate because it's usually underneath of the areola. These usually occur in older 35 to 55-year-old women, and is associated with a slightly increased risk for developing breast cancer. Ductal ectasia, or duct dilation. These are benign breast disease of perimenopausal or postmenopausal females, and usually involve several bilateral ducts in the subareolar area. Could coincide with multicolored sticky nipple discharge being the main symptom, and progress to burning, itching, and pain around the nipple. May also see inflammation and nipple retraction occurring, and again is not associated with cancer. Male gynecomastia. This is a transient non-inflammatory enlargement of one or both breasts. It's the most common breast problem in men, usually a temporary benign condition, and again is not a risk factor for breast cancer. Can occur in puberty, though may also manifest with other problems like testicular tumors, adrenal cancers, pituitary adenoma, hyperthyroidism, liver disease. Could be a side effect of drug therapy or marijuana use. This is not to be confused with senescent gynecomastia, which usually occurs in many older men, likely causes a high plasma estrogen levels, and involves tender, firm, centrally located breast enlargement. Can be discrete, circumcised mass with the gynecomastia, and would need a biopsy to rule out breast cancer. Usually regresses in about 6 to 12 months on its own with no treatment. For gerontological issues, one would be pendulous breasts, and this involves a loss of subcutaneous fat, a loss of structural support, and atrophy of the mammary glands. Also could be decreased glandular tissue density to make breast masses easier to palpate, and increased incidence of breast cancer are involved. Breast cancer. There are many new cases in the U.S. each year, and it's the second most common form of cancer, second only to lung cancer as the leading cause of death in women. Incidence is slowly decreasing due to decreased use of hormone therapy after menopause, early detection and treatment advances. Breast cancer survivors are the largest group of any cancer survivors, however. There are many risk factors for breast cancer. Obviously, female gender and age are going to be a strong risk factor. Other issues including family history, environmental factors, and that strong genetic link. Most who develop breast cancer have no identifiable risk factors, however. Hormonal regulation plays a key part in breast cancer development, though the mechanisms are poorly understood. Could be a combined hormonal therapy to increase risk of breast cancer, increase tumor size at diagnosis, and increase tumor stage at diagnosis. Estrogen alone may increase risk after 15 years. The modifiable risk factors for breast cancer include things like excessive weight gain during adulthood, a sedentary lifestyle, smoking, fat intake, obesity, night shift work, alcohol use, and other environmental factors such as radiation exposure or hair dyes. And as we said, up to 10% of these breast cancers are hereditary. And this genetic link is stronger if involved in a family member. Most are related to mutations of two genes, the BRCA1 and BRCA2. BRCA meaning breast cancer genes. Also mutations of genes that suppress tumor growth. Had a history of ovarian cancers, was premenopausal, had bilateral breast cancer, or is a first-degree relative. In these cases, the risk for breast cancer doubles. Breast cancer is not only an issue for females, however. And the risk factors for men include, again, estrogen use, hyperestrogenism, a family history of breast cancer, radiation exposures, and for these BRCA positive families, consider genetic testing. Teach yourself self-assessment. For women at an average risk, yearly mammograms should be conducted starting at the age of 45, and then every year from the ages 45 to 54. After that, it can go to every 2 years for ages 55 and older, and continue those screening and mammograms as long as the overall health is good. Other options for screening include the clinical breast exams, though the American Cancer Society does not recommend these for average at-risk women of any age. For women at increased risk, options such as earlier 3D mammograms, breast MRIs, or more frequent clinical breast exams may be needed. Here in figure 56.1, just showing you the difference in the modern imaging devices. On A on the left here was a conventional X-ray when compared to a digital X-ray in slide B. Another piece of education you should be including would be the breast self-exam. This would help the patient to be aware of the normal look and feel and hopefully early identify should any changes occur. Other diagnostic studies, again, those digital mammograms, which are more accurate for younger women. Also, 3D mammograms, ultrasonographies, and MRIs for women at high risk. Depending on the size, type, and location of the tumor, there's different forms of biopsy that could be used. Everything from fine needle aspiration, core needle biopsy, vacuum assisted biopsy, or even an excisional biopsy. And in some very high risk cases, prophylactic oophorectomy and mastectomy in women with the BRCA1 or BRCA2 mutations. And this can decrease the risk of breast and ovarian cancers. Ovaries are a main source of estrogen in premenopausal women, and this oophorectomy does not decrease breast cancer risk in postmenopausal women. In the cases of metastasis from breast cancer, the most common sites are bone, liver, lungs, and the brain. There's many factors that can affect this prognosis, everything from tumor size, axillary node involvement, tumor differentiation, and estrogen and progesterone receptor status. There are many different types of breast cancer, and this is a group of diseases characterized by different pathological findings and clinical behaviors. Metastatic breast cancer is one that can spread to other organs, most common sites being liver, bone, lungs, and the brain. The first two types of breast cancer would be the ductal carcinoma and the lobular carcinoma, with a ductal carcinoma affecting the milk ducts themselves, while a lobular carcinoma affects the milk-producing glands. The types of breast cancers can also be characterized by their invasiveness, with non-invasive breast cancers comprising 20% of cases, while the invasive cancers comprising the other 80%. Classification could also be based on their hormone receptor status, meaning estrogen receptor positive or estrogen receptor negative, or progesterone receptor positive or negative. Another clarification could be under the HER2 genetic status. In this case, HER2 refers to a specific set of genes that could cause abnormal cells to grow within the breast. As far as the non-invasive breast cancers, again, these cover 20% of cancers, and they tend to be unilateral, meaning they only affect one breast as opposed to both. Could also go along with things like Paget's disease and lobular carcinoma in situ, which is reclassified as benign, but with a risk for developing into cancer later down the road. In the case of an invasive ductal carcinoma, this is the most common type of breast cancer. It starts in the milk ducts, then breaks through walls to invade surrounding tissue. In invasive lobular carcinomas, these begin again in the milk-producing glands of the breast themselves, the lobules, and account for 10 to 15% of the invasive breast cancers. They're present as subtle thickening in the upper outer quadrant of the breast, and often is not detected by mammograms. In inflammatory breast cancer, this is an aggressive and fast-growing cancer with a high risk for metastasis. The cancer cells block lymph channels within the skin of the breast. The breast begins to look red and feel warm, and as the breast skin has a thickened appearance, it looks like an orange peel. Paget's disease of the breast, not to be confused with Paget's disease of the bone, is a rare form of breast cancer. It starts in the breast ducts and spreads to the nipple and areola, and it's characterized by itching, burning, bloody nipple discharge, and ulceration. These nipple changes, often diagnosed as an infection or dermatitis, which can lead to delays in treatment. A very rare form of tumors is a Phyllodes tumor, and it develops within the connective tissue of the breast. Unfortunately, it tends to grow very quickly, though most are benign, and treatment involves excision with a wide margin. Triple-negative breast cancers are tests that negative for all three receptors. These include estrogen, progesterone, and the HER2 genes, and unfortunately could have higher rates within premenopausal women as well as BRCA1 mutations. This is a more aggressive tumor with a poorer prognosis and does not respond to hormone therapy. Chemotherapies tend to be more successful. Clinical manifestations of breast cancer are often first detected as a lump thickening or mammogram abnormality within the breast. and the rate of lesion growth can vary depending on its type and individual genetic makeup. If palpable, hard, irregular, poorly delineated, non-mobile, and non-tender, there may be nipple discharge or retraction as well. Here in figure 56.3, we just have a breakdown of where most breast cancers tend to occur within the breast. Complications include recurrence and metastasis. Everything from local metastasis to regional to the lymph nodes, and distant, including the bones, brain, lungs, and liver. And metastatic disease can be found at any distant site. Some tests are used to predict the risk of local or systemic recurrence, including axillary lymph node analysis, tumor size, estrogen and progesterone receptor status, cell proliferative indices, and genetic and genomic assays. One important prognostic factor would be the axillary lymph node analysis. And this is important because the more lymph nodes involved, the greater the risk of recurrence. In the case of a sentinel lymph node biopsy, this could be used to help identify lymph nodes that drain first from the tumor site and may indicate need for a complete axillary lymph node dissection. Another important diagnostic factor would be the tumor size itself. As the larger the tumor, unfortunately, the poorer the prognosis. Also, the more well-differentiated the tumor, the less aggressive. Poorly differentiated tumors appear morphologically disorganized and tend to be more aggressive as well. Further diagnostic studies, estrogen and progesterone status is going to be a key thing to identify, with receptor-positive tumors often well differentiated and a lower chance for recurrence. The diploid DNA content and low proliferative indices, and are frequently hormone dependent and respond well to hormone therapy. Receptor negative tumors, on the other hand, are often poorly differentiated and frequently reoccur, and unfortunately can be unresponsive to hormonal therapy. Under the genomic assay, that HER2 is again that prognostic indicator associated with unusually aggressive tumor growth, greater risk for recurrence, and another poorer prognosis. This presence helps in the selection and sequence of the drug therapy and helps to predict its response. For a gene expression assay test, this would involve using a sample of breast cancer tissue to analyze the activity of a group of genes that can affect how that cancer is likely to behave and respond to treatment, such as with an oncotype DX. And finally, cell proliferative indices indirectly measure the rate of tumor cell proliferation. Patients with cells that have high S-phase fractions have higher risks for reoccurrence and earlier cancer deaths. There's going to be a lot of professionals and specialties working collaboratively in the care of these patients, and these wide range of treatment options are available to both the patient and the provider to make critical decisions. Treatment plan is often determined by prognostic factors, the clinical stage of the cancer, and the biology of the cancer itself. For the staging of breast cancer, we would use the TNM system, meaning the tumor size, the nodal involvement, and the presence of metastasis. The stage of the breast cancer describes the size and extent to which it is spread. All options should be considered and discussed, including surgical intervention, radiation therapy, drug therapy, hormonal therapy, and immunotherapy, along with targeted therapy. For surgeries, the most common surgical procedures for operable breast cancer include lumpectomies and segmental mastectomies. For breast-conserving surgeries, a lumpectomy would involve removing the entire tumor with a margin of the surrounding normal tissue. Radiation therapy after the surgery would be common and is delivered to the entire breast, ending with a boost to the tumor bed. And finally, chemotherapy would be initiated before the radiation therapy. Contraindications for the breast-conserving surgeries would include the size of the breast in relationship to the size of the tumor, a multifocal masses and calcifications, multicentric masses in more than one quadrant, diffuse calcifications in more than one quadrant, and prior radiation therapy. A total or simple mastectomy may be necessary, which involves the removal of the entire breast. A modified radical mastectomy, on the other hand, removes the breast and axillary lymph nodes, while preserving the pectoralis major muscle. And finally, a nipple-sparing mastectomy would only remove that underlying tissue. Following a mastectomy, breast reconstruction surgery can be done with a mastectomy or it can be delayed. This reconstruction is optional and includes two main types: implant reconstruction or tissue flap. When considering radiation therapies, the goal is to prevent local cancer reoccurrences after breast conserving surgery. We want to prevent local and lymph node reoccurrences after the mastectomy and relieve pain caused by local, regional, or distal spread of the cancer. For external radiation, this is often done after the breast cancer surgery, with the decision based on the chance that residual cancer cells are still present, and includes radiating the axilla and/or supraclavicular nodes when indicated. Unfortunately, this does not prevent distant metastasis. And adverse effects include fatigue, skin changes, and breast edema may be temporary. Another option may be brachytherapy, which involves the placement of radiation internally and is minimally invasive, delivered directly into the cavity left after the lumpectomy. It requires 5 treatments at approximately 5 to 10 minutes each. Here in figure 56.7, we have a diagram showing just how that brachytherapy is achieved and the radiation is applied directly to the tumor site internally. Another indication for radiation therapy may be palliative, and this is done to decrease the pain by reducing the primary tumor mass. This treatment option is for symptomatic metastatic lesions in the bone, soft tissue organs, brain, or chest, and often relieves the pain, controls recurrent or metastatic disease. There will be many options for drug therapy, including chemotherapy, hormone therapy, immunotherapy, and targeted therapy, and these are indicated for patients at increased risk for metastasis. These drug therapies can come in 2 options: neoadjuvant or adjuvant therapy. In the case of neoadjuvant therapy, this would be given before surgery to shrink the size of the tumor, versus the adjuvant therapy is given after therapy to decrease the rate of recurrence and increase the length of survival. Chemotherapy involves the use of cytotoxic drugs to destroy cancer cells. It's a combination therapy that's usually superior to the use of a single drug. Usually given for 3 to 6 months, with metastasis they may receive for the rest of their life. Again, chemotherapy is a combination of drugs, each with different mechanisms of action that affect different parts of the cell cycle. And there are common combination therapy protocols used within both the adjuvant and neoadjuvant setting. Side effects of chemotherapy are related to the drug combination, the schedule, dosage, and involve rapidly dividing cells within the GI tract, the bone marrow, and the hair follicles in the case of alopecia. On the other hand, hormone therapy works to block the effects and source of estrogen, promoting tumor regression. Estrogen can unfortunately promote the growth of breast cancer cells if these cells are estrogen receptor positive. Receptor assays have been developed for both estrogen and progesterone to predict whether hormone therapy is a valid treatment option. The hormone therapy works to block estrogen receptors and suppress estrogen synthesis. Another option to lower the rates of estrogen would be ovarian ablation, used in premenopausal women with estrogen receptor positive breast cancers, and is usually accomplished surgically. There are many estrogen receptor blockers on the market, with tamoxifen being the most common. And this is a drug that comes up a lot in ATI and NCLEX you're going to see. And keep in mind with this drug, the adverse effects often mimic menopause, with symptoms such as hot flashes. Another hormone therapy is aromatase inhibitors, and these stop aromatase, an enzyme located within the fat tissue that works on changing other hormones into estrogen. They're used in the treatment of breast cancer in postmenopausal women, but keep in mind they do not block ovarian estrogen production, may be harmful in premenopausal women, and may cause osteoporosis in postmenopausal women. And finally, estrogen receptor modulators that work to suppress hormone-dependent breast cancer tumors. There are also many targeted therapies, such as Herceptin, which attaches to HER2 receptors on the surface of breast cancer cells and blocks them from receiving signals to proliferate. It can be used alone or within a combination of other chemotherapies. Another option may be kinase inhibitors, which prevent cells from dividing, slowing their growth. These are indicated for estrogen receptor positive, HER2 negative cancers in postmenopausal women. And immunotherapy, which includes drugs such as Tecentriq, You have to wonder who writes these drug names. And these work as an immune checkpoint inhibitor and is the first FDA-approved immunotherapy agent. It's used with chemotherapy to treat locally advanced triple-negative breast cancers. The care of cancer and the treatment of cancer can be a long and complicated process, which can be further complicated based on each of your patient's individual needs and requirements. There are many changes throughout different cultures, socioeconomic backgrounds, involving the incidence, mortality rates, and the care issues required. For our nursing assessment, we want to include a lot of factors, including the history of breast problems that helps us establish a diagnosis. Things such as the presence of nipple discharge, including color, consistency, and is it in one or both breasts. Also factors such as pain, the rate of the growth of the lump, any breast asymmetry, and any correlation with the menstrual cycle. Breast cancer can often be an especially difficult diagnosis to deal with, coming with its own unique set of problems, including patient issues such as difficulty coping or negative self-image. For planning, our overall goals are that the patient will actively take part in the decision-making process, adhere to the therapeutic plan, communicate and manage side effects of the therapy, be supported by their significant other or outside family members, and adhere to the recommended follow-up treatments and surveillance. Prevention is always the best treatment, and we can reduce many of the risk factors for breast cancer by maintaining a healthy weight, exercising regularly, limiting alcohol, eating nutritious food, and stopping smoking. These risk reduction options will be especially important, such as for patients that are positive for the BRCA gene and other mutations. They may even consider prophylactic oophorectomy after counseling about the risks, benefits, and any potential fertility issues. Waiting for biopsy results must be a long and stressful wait, and the treatment recommendations itself is stressful. Make sure to clarify and expand on all treatment options provided by the healthcare provider. Assess their coping levels and strategies, and explore usual decision-making processes with the patient and their family. And remember, that patient is always an active participant in their care, and we need to make sure we're providing enough information to ensure they can provide informed consent. Be sensitive to their needs and their preferred type of information. Everyone has different learning strategies and different preferences for processing complex information. If they prefer reading and writing, provide written material. Provide detailed explanations in simple terms. We want to make sure that the patient understands exactly what is going on and what their options are. Pain is going to be a major priority, especially post-operative. And we want to make sure we're giving regular analgesics, we're assessing for this pain, and even premeditating before exercises. We also want to teach drink care at may be needed to take home with them. And restoring that arm function on the affected side after breast surgery is a key nursing goal. Here in figure 56.7 is just a diagram demonstrating some of the exercises that may be necessary to restore that proper arm function and improve their abilities with their activities of daily living. We also want to be able to teach the patient about what symptoms they should report for things like fever, inflammation, redness, or unusual swelling. We also want to make sure we're educating the patient on measures to prevent and reduce lymphedema, such as no blood pressure readings, venipunctures, or injections on the affected side. The arm should not be dependent for long periods, and to prevent infection, burns, or any other compromised circulation within the limb. We also want to make sure we're encouraging exercise and maintaining that normal weight to put as little stress as possible on that arm. Other strategies to reduce that acute lymphedema include a massage-like technique to mobilize the subcutaneous fluid accumulation. Also consider compression bandagings, pneumatic compression sleeves, elevating the arm, and isometric exercises. Here on figure 56.8, we have a picture showing just how swollen that limb can become with acute lymphedema. Other major things to consider would be post-breast therapy pain syndrome and other complications related to damage to the nerve endings from the surgery. The symptoms of post-breast therapy pain syndrome include symptoms ranging from mild to debilitating, affecting the chest and upper arm pain, tingling, aching, burning, numbness, shooting or prickling pain, edema, and unbearable itching. There would be many different treatments used for this as well, depending on the severity. Everything from NSAIDs, low-dose antidepressants, to topical anesthetics. Phantom breast pain, just like phantom limb pain in a patient post-amputation, is a feeling of pain in a breast after a mastectomy, and the brain continues to send signals to nerves in that breast area that were removed during the surgery. We want to make sure that all aspects of our care include sensitivity to the complex psychological impact of both the diagnosis and the treatment plan. Provide a safe environment for expression of all feelings, and help identify sources of support and strength for the patient. For psychosocial support, we want to encourage the patient to identify and learn personal coping strengths, promote communication between the patient and their family, provide accurate and complete answers, and always be ready to refer them for other support resources. We also want to make sure we have thoroughly educated the patient on the plan following discharge as well, as they're going to be receiving a lot of outpatient and ambulatory care at this time, including things like explaining the follow-up routine and emphasizing the importance of ongoing monitoring and self-care, and teach exactly which symptoms they should be immediately reporting to the healthcare provider. Other things to educate the patient on would be information for mastectomy patients, including special garment choices and breast prosthesis, and address the implications of a cancer diagnosis and breast surgery on body image and their other interpersonal relationships. On the positive side, breast cancer survivors is the largest group of cancer survivors and number almost 3 million. This number is also expected to continue to grow as our population continues to age. After surviving breast cancer, they'll still see the healthcare provider 1 to 4 times a year for the next 5 years and then annually. For our expected outcomes, we want to identify activities that can reduce post-op edema, improve their mobility, show an effective use of coping strategies, and help them identify further resources to support them after discharge. As we previously discussed, age is a major factor in breast cancer diagnosis, unfortunately. And more than half of all breast cancers occur in women aged 55 or older. Older women are less likely to have mammograms, and screening and treatment decisions are based on the health status, not the patient's age. During recovery, a mammoplasty may be considered, and this is a surgical change in the size or shape of the breasts. It could be an elective surgery for cosmetic purposes, breast reconstruction, and consider things like body image, other outcomes, complications, and the values of each individual patient. The goals of breast reconstruction include things like achieving symmetry, restoring and preserving that body image, and the timing is based on the patient's physical and psychological needs. They could be immediately after surgery, or they could wait until they've recovered a bit. There are different forms of implants, everything from silicone gel, saline, to a cohesive gel. Another option may be a tissue flap procedure. This involves the use of autologous tissue to recreate a breast mound. This tissue may be obtained from places like the abdomen, the back, the thigh, or even the buttocks. Here on figure 56.11, it's just another diagram giving you a better idea of how that autologous tissue is obtained to recreate the breast. These surgeons may have a variety of different techniques they could use to obtain that tissue, such as the tram flap technique. Nipple areolar reconstruction may be another technique used, and this is done to keep a more natural appearing breast, and it's usually done several months after the breast reconstruction. In this case, tissue is taken from the breast tissue to create a new nipple. Tattooing with permanent dye may also be used. Here in figure 56.9 is just a diagram of how successful some of these reconstruction surgeries can be. Augmentation mammoplasty may be used to enlarge the breasts. And in this case, an implant is placed in a surgically created pocket between the capsule of the breast and the pectoral fascia. Breast reduction surgeries are more common than you may realize, as large breasts can be a source of discomfort. In this case, wedges of tissue are resected from the upper and lower breast quadrants. Excess skin is removed, areola and nipples are relocated, and lactation can still usually occur following this procedure. Another cosmetic surgery is the breast lift, or a mastopexy. In this case, it's a surgical procedure to change the shape of the breast, remove excess skin, and reshape that tissue to raise the breasts. For nursing management, both breast augmentation and reduction are a major surgery completed under general anesthesia. Drains are going to remain in place until drainage is under 20 to 30 milliliters a day. As nurses, just like any other surgery, we want to be assessing for infection and hemorrhage. Monitor the patient's temperature, change the dressings using sterile technique as ordered, and a bra may be worn continuously for 2 to 3 days for additional support. Audience response question. During a routine health exam, a 32-year-old patient tells the nurse she does not perform breast self-examinations. What's the most appropriate statement for the nurse to make? A. Breast self-examination has little or no value. B. Breast self-examination is an option for all women. C. It's important for you to do monthly breast examinations. Or D. Yearly breast examinations are not frequent enough. The correct answer here is B. Breast self-examination is an option for all women. Additionally, women at increased risk should discuss with their healthcare provider both the benefits and limitations of starting mammograms earlier. And our last question for this module. The nurse is preparing to teach a group of women about breast cancer risk factors. Which risk factors should the nurse include in the teaching plan? A. Women older than 50 are at greatest risk for breast cancer. B. The BRCA1 and BRCA2 genetic mutations cause most breast cancers. C. Early menopause before age 50 increases the risk of breast cancer. Or D. 1 to 2 alcoholic beverages per day decrease the risk of breast cancer. And the correct answer here is A. Women older than 50 are at greatest risk for breast cancer, as the risks of this condition do increase with age. Anyway, that's all I've got for this chapter, and I'll see you in the next slides.